And today really is the last day with new material. It's a bit packed, unfortunately. I know it's a lot of information in one day today. Probably today is about the most information in one day. But we've come a long way. We've come a long way in the course. You remember way back when we first started? We had our motivation day, right? We saw our video of the children who were HIV positive and talking about what it's like to be HIV positive. We talked about epidemiology, like what's happening in South Africa, the country with the most HIV infections anywhere in the world. And then we talked about prevention strategies, all in an effort to motivate you, to get you interested in HIV, get you interested in learning the lecture material. We also had our pretest, which we know the class average was around 50%, so knowing that there's lots of new things to learn. Then we had our guidelines lecture, right, where we talked about what are the new guidelines. Brand new guidelines came out April 1st, 2010. So what were these new guidelines for adults? What were the new guidelines for pediatrics? And then we sort of took our imaginary patient and walked them through the process of first diagnosing them with HIV, and then assessing who qualifies for ARVs, who needs ARVs, what happens to somebody once they're HIV infected, and then who needs treatment, who doesn't need treatment. Now we talked about how do you assess somebody before they start treatment. What does the patient need to learn about taking treatment today? And we talked a little bit about that today in the resistance lecture. And then we talked about the medicines that they're likely to take, all the medicines, their doses, the side effects, all those sorts of things. And then we talked about adherence. So once you're on treatment, the medicines, the side effects, and then how important it is to take it every day. And we heard that again and again and again, and we heard it again in the resistance lecture, how important it is to take it all of the time. Over 95% of the time is what's required. Otherwise, resistance can develop. And then we talked about disclosure, something that can help benefit adherence and help people learn about their HIV status. And then we talked about the PMTCT and prevention of mother-to-childhood transmission, infant feeding practices, all of these things. And then today is sort of a mixture of everything else. The 3 lectures today were not part of the original course when I first designed this course 3 years ago. These 3 lectures were not in there. But they all came up as very, very important parts to learning about HIV. Questions that always come up are always about resistance. They're always about side effects and toxicity, and always about TB. So those are the 3 lectures for today. So that's why we started off with resistance, because it's a very, very common topic. It's what sets HIV medicine and dealing with HIV aside from really everything else. It's what sets it aside from diabetes. It's what sets it aside from high blood pressure. It's because this virus can become resistant. And it can become resistant very easily, as you saw in the lecture. And a lot of those things that Dr. Matthews talked about are things that we see every single day. Every single day. Some of the children with the worst resistance I've ever seen, and that have had to be on salvage medicine, had to have applied for new medicines that aren't even available in South Africa, are because of some of the mistakes that were made that Dr. Matthews talked about. You know, one of them was a child who initiated ARVs in a private doctor when he was a small child and was on ARVs for 5 years. In the time, he gained about 25 kilos. But he was on the same dose he started 5 years ago. So he became resistant. It wasn't his fault. He took the medicine. Mom was excellent, gave the medicine every day, had very good adherence. But the doctor never increased the dose for 5 years. Child gained 25 kilos in that time and became resistant. So it's not always adherence. I know we always focus adherence, adherence, adherence. It's adherence that causes resistance, but it's not always. Another common one that I see Dr. Matthews also mentioned is patients come in to us, the doctors, we're doing their ARVs. They go to the clinic because they've had a cough for 3 weeks. And somebody at the clinic decides, oh, this person has TB. They start them on TB treatment. Don't ask them if they're on ARVs. Don't check what medicines they're on. And this person's on Kaletra or Alluvia. They don't change the dose. It's been a month before the patient returns to the ARV clinic, or if they're on chronic prescription, they may not see the doctor or nurse or counselor for 6 months. All that time they were taking TB treatment in Kaletra or Alluvia. We see it all the time. That gives them a chance to be resistant. Lowers the effective dose of Kaletra. We're going to talk about that in the TB lecture this afternoon. Things we see all the time. So it's not always just adherence that leads to resistance. It can be other things, wrong doses, drug-drug interactions, those sorts of things. Okay? Malabsorption, people aren't absorbing the medicines very well. All right, and so the next topic we're going to talk about, and this again is something that lots and lots of questions come up upon, lots of questions about side effects of the medicine and toxicity. And so that's the point of this lecture here now. This is going to answer lots of your questions about the most common side effects that patients on ARVs get, like lipodystrophy, like lactic acidosis, like peripheral neuropathy. All of these things, hopefully, now that we're using more tenofovir, more abacavir, that we're going to start seeing less and less and less and less of. But already, as of 2010 in South Africa, there's about 500,000 patients, about 500,000 patients in South Africa on ARVs already. Most of them are on a D4T containing regimen. As we know, D4T is one of the most toxic medicines that's available. So we're going to see these side effects. Okay, this is why you need to learn why does it occur, how does it occur, and what do you do about it. And that's the purpose of this lecture today. So I'm going to start with some cases, and again, these are very real cases. All of these I could put up about 4 or 5 cases that I saw this week. But these are all cases that I've seen, and you'll probably, all of you have seen very similar and representative cases. Okay, so this first one is a 37-year-old male. He's on regimen 1A, which, as you recall, is Stoker and D4T3TC. He'd been on for a little over a year. His initial CD4 was only 28, and it went up in 6 months. It skyrocketed to 247, a very good response. And then by 12 months was up to 432. So this is a sort of an atypical person doing extremely well, very, very well. To go from 28 to 432 in just a year is a very good response. His weight responded initially very well, went up from 62 kilos to 74 kilos, but now is dropping back down again. And now he's tired, saying he doesn't have much energy to get out of bed. He just feels tired all the time, feels sluggish. He's been vomiting for the last few weeks. He hasn't been having diarrhea, though, and just says his belly's not feeling right, just not wanting to eat. Just doesn't feel right anymore. So he came to see us. We examined him. We didn't see anything terribly abnormal. His abdomen was soft, mildly tender, no guarding, no rebound, had normal bowel sounds. His liver and spleen were of normal size. He went to the clinic because of this. He got some antibiotics, but nothing didn't seem to help. They worked him up for TB at the clinic because of this, because of the weight loss too. He had sputum twice that was negative. He had a chest x-ray done, and it was all clear. So he's had several courses of antibiotics, still vomiting, still losing weight, still not feeling right. Exam's pretty normal, and it's probably not TB. Think about what that might be. And then we have another case, 35-year-old female, also on 1A. She started again with a very low CD4 count and a very high viral load. Her weight was 47 kilos. CD4 responded very well to 212 at 6 months. Viral load undetectable, so we know she's taking her treatment very well. 12 months, even better, 64 kilos. Look at that, she's gained lots of weight in 1 year, and viral load still suppressed. But she says, my clothes don't fit anymore. I have lipodystrophy. Change my medicines. This actually happened to me. The very same thing happened to me on Tuesday. I was at McCord. Patient stopped me and said, "Doctor, you know, I'm doing very well on ARVs. I'm feeling great, but I'm getting fat. Change my medicine." We're going to talk about that, okay, and what to do about that as potential side effects for the medicines, okay? So think about those two when we talk about these side effects of the medicines. Gentleman losing weight and vomiting, not feeling right. Another woman who's doing extremely well, CD4 skyrocketing, viral load staying suppressed, but saying her clothes don't fit. It's costing her too much money to keep buying new clothes, so we need to change her medicines. So what do we evaluate in terms of toxicity? Remember my 6 things that you must always do every patient, every visit, right? Check on their clinical response, their immunologic response, their virologic response. Check for toxicity, which is what this is. Check their adherence and check their disclosure status. 6 things every single visit you must do. So what do I mean when I say check for toxicity? Well, these are the things you do. You can check them in 2 different ways. You can check them clinically. Ask the patients, how are you doing? Are you having side effects? Are you feeling anything abnormal? Okay. Well, what are we looking for by doing that? Well, neuropathy. Are they having painful hands, painful feet? Are they feeling numbness in their hands and feet? Okay, that's signs and symptoms of neuropathy. Okay, rash. Some of the medicines, particularly nevirapine, abacavir, can cause a rash. So you need to ask them, are you having a rash? You need to examine them, look for these types of rashes. Pancreatitis, side effect of the medicine, can cause severe abdominal pain and vomiting. Okay, particularly after somebody eats. They eat and their belly pain gets very, very bad and causes vomiting. Okay. Jaundice from liver failure. Are they turning yellow? Are their eyes turning yellow? Skin color turning? Lipodystrophy, are they gaining weight? Are they losing weight? Okay. And what is happening with their weight? Are they losing weight? Maybe that's a sign of lactic acidosis. So those are the things you can all check for clinically by examining them and asking them questions. There's also types of toxicity that we look for from the labs. Look for elevated liver function tests. Look for anemia, side effect of AZT. Look for elevated blood sugar, like Calitra and some of the other protease inhibitors can cause elevated blood sugar. So we need to check that. And the same is true about triglycerides, side effects of some of the protease inhibitors. So what do you do about the toxicity? Well, depending on how bad it is, we typically grade the toxicity. Grade 1, 2, or 3, or 4. Now this, I'm not going to go through what is grade 1, what is grade 2, what is grade 3, what is grade 4. But you have this as a reference, you can look it up. The important thing is that you do it, that when somebody has a toxicity, you evaluate how severe is it, how bad is this type of toxicity. The reason that we grade it is because what you do about it is based on the grade. Again, these are some other things that you can grade. So if it's grade 1 or grade 2, somebody's having mildly elevated liver function tests. They're really, most patients who are 1 or 2 are pretty asymptomatic. Slightly anemic on AZT. Slightly elevated liver function tests above normal. Most of the time they're asymptomatic. We usually continue treatment. You should repeat the test to make sure that the lab was not in error, or that that the liver function tests are not getting worse, or the anemia is not getting worse. And you just continue to monitor them clinically. If it's getting worse, and now we're talking about stage 3, stage 4 disease, then these can be more serious. The test should be repeated within 1 week of you getting the result. And if it's still grade 3 or grade 4, then you need to stop the medicines. Okay? And we don't just stop one medicine, right? If we think it's the D4T, we don't just stop the D4T. Why not? Right. Because you can get resistance, right? We know that it's probably the D4T causing, say, peripheral neuropathy, but we don't just stop that one, right? Because of resistance. So you must stop all of them. So when somebody gets a rash with nevirapine, we don't say, okay, stop the nevirapine and continue everything else. No, you must stop everything. Somebody gets a rash and fever with abacavir. They stop everything, because otherwise it might lead to resistance. Okay? So they stop all of their medicines, and then of course seek expert medical advice for anything grade 3 or grade 4 to discuss when should we restart. Now grade 4 toxicities, these are an emergency. These are usually life-threatening. These are severely elevated liver function tests, very low hemoglobin, severely anemic patients, very bad peripheral neuropathy. They can no longer walk anymore. Severe rash, Stevens-Johnson syndrome, we're going to talk about at the end of the lecture today. Severe, severe, severe reactions, severe side effects. These patients all need to stop their medicines immediately. Not waiting for repeat tests, not waiting for anything. They should stop there immediately. Most of these patients need to be hospitalized. And then we can talk about when to restart. The treatment usually is up to a specialist, an expert in it. If they're having severe lactic acidosis, severe peripheral neuropathy, severe anemia, severely elevated liver function tests. Okay? Okay, so the first thing we're going to talk about, the first toxicity is probably the most serious, and that's lactic acidosis. So if you recall, case 1, gentleman who was doing very well on treatment had a very dramatic response in CD4, viral load undetectable, initially gained 12 kilos in just 6 months, but is now losing weight. Now losing more weight, losing 6 kilos in 6 months. And he's presenting with fatigue, loss of appetite, abdominal pain. He's had courses of antibiotics, has not helped. He's been checked for TB, doesn't seem to have TB. Okay, his exam is pretty normal. What do you think is going on? Obviously, the title of this section, but what do you think this might be? Right, this could be lactic acidosis. And so how do we confirm this? How do we say that this is or is not lactic acidosis? What test would you do? A lactate. That's very good, and most clinics have a small little lactate machine that you can do and get the answer right away within 60 seconds. But are there other tests you'd like to draw and maybe send off to the laboratory other than a lactate? UNE is very important when also evaluating lactic acidosis, because the lactate level does not tell you if a patient is experiencing lactic acidosis. It only can tell you that the level of lactate is elevated. Lactic acidosis means that there's also acid, too much acid in the blood, that the body's not compensating for. The only way to check for that is by doing a UNE, and you check the bicarbonate and calculate an anion gap. If the bicarbonate is low, there's a large anion gap, then there's a high chance that this patient is experiencing lactic acidosis, and that's very serious. So yes, a UNE is another blood test I would check. I would also check liver function tests, because often patients who are developing lactic acidosis also have liver function abnormalities. And that's one of the causes of lactic acidosis, is they're not metabolizing their medicine very well, and they're getting side effects from the medicine because of that. So as of 2007, there were about 300,000 patients on ARVs, on HAART. Now it's almost 500,000 by 2010. It's almost 500,000 patients in South Africa on ARVs. Okay? Patients are surviving longer, which means they're developing more long-term side effects. If you remember back to the lectures when I told you about D4T, when we talked about the side effects, I told you those side effects don't occur right away. They don't occur in the first few weeks on treatment. They occur longer. And as I said, and we talked about in one of the review sessions, the risk of developing these side effects are highest in people who take the medicines well, who take it every day. The longer they take it, the higher the chance of them developing it. So the more long-term side effects are going to start to accumulate now that more people are on treatment for longer periods of time. As I showed you this figure in the very first lecture I gave about epidemiology, the projected number of patients on ARVs, even if we're only at 50%, which at 2010 we're over that we're less than 50%, on treatment that require it, but we're batting at about this 20% line. So it said by 2010 we'll get about 500,000 patients, and that's actually where we are, because we're actually at about 30% coverage currently in South Africa. So we're between these lines. And what's projected to happen in the next several years, well, if we remain at 30% or even increase, look, probably by about 2011, maybe even next year, maybe even by 2012, we'll have 1 million patients in South Africa on treatment, on ARVs. So in the next few years, about 1 million patients in South Africa will be on ARV. So these side effects you're going to start seeing them more and more and more and more frequently. So what causes lactic acidosis? Well, it's a complicated thing. It's called mitochondrial toxicity. Now, we're going to be going through a bit of science here. Now, it's not completely important that you understand the terms and the terminology that I use, but it's important that you understand the concept. Okay? And I hope that you understand how these medicines work, and so why do they have these side effects. And the reason and the underlying answer between most of the side effects of ARVs is mitochondrial toxicity. So what is that? I'm going to tell you now. So what is a mitochondria? A mitochondria is something inside a cell. It's inside every single cell inside the body, except for the red blood cells. So everything else inside the body has these mitochondria in it. So they must be very important, right? Well, they are very important, because their job is to take the energy, or to take the food that we eat and turn it into energy. So that's a very important job, isn't it? Their job is to take glucose, take sugars that's broken down from the body, and it takes that through a bunch of chemical processes and turns it into energy. So energy is pretty important, isn't it? Without energy, you'd be dead. You couldn't do anything. Your cells couldn't do anything. Nothing could happen. Okay? You couldn't breathe. You couldn't walk. Your body couldn't digest anything. Your heart can't beat. Okay? Nothing can work inside the body without energy. So these are very, very important, among the most important things inside the body, because they take what we eat and turn it into energy. Okay? So that's one of their main jobs. And they have another job. In doing so, in turning that, there's some byproducts. There's these things called oxygen-free radicals. And the mitochondria takes these things and keeps them all within inside them. So what's an oxygen-free radical? Well, I like to think of them as little bombs. They're little reactive bombs that, if they get outside the cell and they float around in the body, they can explode and cause damage to all different things. But if they're kept inside the mitochondria, then they're safe, right? Similar to Lynn's picture about the elephant in the box, right? If we keep all these little bombs inside the box, they're safe. But if they get out, then they can explode and damage all sorts of other tissues. Anything else in the body can start to damage. So it's two very, very, very important types of function. To keep these little oxygen-free radicals, these little time bombs, contained in one area, and to take food and turn it into energy. Okay? So the mitochondria is also very special because it doesn't replicate and doesn't make more of itself the same way that everything else in the body does. It's the only thing that's different. It's the only thing that does it. And it does it not through regular DNA, but something that's different called mitochondrial DNA. And mitochondrial DNA, it can't fix itself like regular DNA. It doesn't have the same way. Similar to how when the HIV virus takes RNA and turns it into DNA, it makes mistakes. Well, mitochondrial DNA takes mitochondrial DNA and turns it directly into mitochondrial DNA. And it can't fix the process if it makes mistakes. Okay? So, why are we talking all about this? Because the NRTIs, your nucleoside reverse transcriptase inhibitors, which are the backbones of ARV therapies, most patients are taking how many NRTIs? 2, right? 2 of them. So they're taking 2 of them. Well, because this mitochondria does things differently than the whole other body, okay, it takes mitochondrial DNA and turns it into mitochondrial DNA. It's very similar to how the HIV virus takes RNA and turns it into DNA. It's very similar. So guess what these things do? And the enzyme that does that takes mitochondrial DNA and turns it into regular DNA, is called mitochondrial DNA polymerase gamma. Very long name. But that enzyme looks very similar to reverse transcriptase. So that when we take an NRTI, sometimes that NRTI mistakes this mitochondrial DNA polymerase gamma for reverse transcriptase. And so it attacks that instead, because they look very similar. They do very similar things. So this is a picture just showing you exactly that. So this DNA polymerase gamma, its job is to take a mitochondria. This is a picture of a mitochondria inside. These are our little time bombs all stuck inside. And to make more of itself, it takes mitochondrial DNA. This enzyme, this machine, turns it into more, and it makes more of itself. And they just make more and more and more and more. But if you're taking an NRTI, sometimes that NRTI blocks this machine on accident. Doesn't mean to do it, but it looks similar to reverse transcriptase. And so instead of just dismantling reverse transcriptase, sometimes it dismantles DNA polymerase gamma. And so if it does that, and if it damages that enzyme, it damages that machine, then your mitochondria can't make more of themselves, can they? Or when they do make more of themselves, it's not the correct form, and it's not the exact right thing. And it might be malformed. It might not work properly. So that can become a problem. Okay? So what happens if you have mitochondria that can't do their job, or you're making malformed mitochondria? Well, electron leakage from the electron transport train, which means those little time bombs can escape. And then those time bombs can start to damage other tissues. Not only that, this is the thing that makes energy, right? This is our little generator. If that's not working, you can't make energy. Or you have to do it in another way. The body is designed so that even if the mitochondria is not working, you can still make energy, but you can make it a different way. And that different way is called glycolysis. Okay? And that's the process of the body making energy. This is just all the chemical processes of taking glucose, turning it into energy, happens through a funny thing called glycolysis. If you remember back to matric years and learning about Krebs cycle in biology, that's how you make energy, through ATP. And all of this happens inside a mitochondria. Okay. If that doesn't happen properly, if you can't have glycolysis, which happens inside the mitochondria, and that's the normal way to make energy, your body has a backup system. And that's called the pyruvate pathway. Okay, so you can still make energy, but guess what? There's a few problems with it. It's not as efficient. It doesn't make as much energy as glycolysis, the pyruvate pathway. And there's also byproducts. Okay, there's byproducts. There's side effects from it. Normally in glycolysis, this is just a picture showing all those crazy reactions. And ATP is the chemical really name for energy. That's what we do. The normal process of glycolysis inside the body happens inside a mitochondria. We take in food in the form of glucose. The body turns it into energy. There are byproducts from that process. Right? There's two main byproducts from that normal process. That's carbon dioxide and water. Since this is the normal process that happens inside the body has designed very good ways at getting rid of those byproducts. How do we get rid of water? By urinating, right? Sweating, even breathing, we get rid of some water vapor. So we have a very good ways of getting rid of water, right? Even when we make stool, you're getting rid of some water. So there's like 4 or 5 ways to get rid of water. Some of it just evaporates from the skin, even when you're not sweating. So you get rid of water lots of ways, right? So it's designed into the process. You automatically get rid of that extra water. Through urinating, through defecating, through sweating, even from breathing, you get rid of water. Right? One of the byproducts of making energy. The other byproduct is carbon dioxide. How do you get rid of that? How does the body get rid of carbon dioxide? By breathing, right? We breathe in oxygen and we breathe in carbon dioxide. Where does that carbon dioxide come from? It comes from glycolysis, which happened inside a mitochondria, which was to produce energy. So the carbon dioxide is a side byproduct of you making energy. So the body does this pretty well, right? Because every second of the day you're breathing. You should be breathing 16, 18 times a minute, getting rid of carbon dioxide. All day you're sleeping, it doesn't matter, you're still breathing, you're still getting rid of carbon dioxide. So it's designed into the system to get rid of these byproducts very easily. Simply by breathing, urinating, defecating, sweating, all these things help you get rid of those byproducts. The problem is, if the mitochondria is not working or not working properly, the body has to make energy a different way. And that happens outside of the mitochondria, and it makes byproducts. The major byproduct of the body not making energy through glycolysis is lactic acid. How does the body naturally get rid of lactic acid? Well, the kidneys can help a little bit, the liver helps a little bit, but it's not designed into the system, right? It's not a normal process. Your body's designed to get rid of a little bit of lactic acid, because you can get lactic acid from many different ways. But if suddenly there's lots and lots of lactic acid around, the body doesn't know how to get rid of it. It can't cope with it. It's too much. It's not part of the regular system. The kidneys get overwhelmed, the liver gets overwhelmed, and it can't do it. So what will happen? If your body's making more and more lactic acid to make energy, it's building up and your body can't get rid of it, what happens to the lactic acid levels? It gets higher and higher and higher. And why is that happening? Because the medicine you're taking, an NRTI, is causing damage to that enzyme DNA polymerase gamma. It's not meaning to, but it's mistaking that for reverse transcriptase. It's damaging that enzyme as well, dismantling it. The mitochondria can't work. Lactic acid builds up. Okay. So what are the NRTIs? Most people, as we said, are taking 2 of them. So there's lots of them. AZT, D4T, DDI, 3TC, emtricitabine or FTC, abacavir, tenofovir, and DDC. Now, most of these now are available in South Africa. The one that's not easily available, but I think it's becoming more available, is FTC. Everything else is now pretty easily available in South Africa. That didn't used to be the case. Even a year ago, when I gave this lecture, that wasn't the case. And one of them, DDC, is taken off the market. You can't get it anywhere. And why is that? Why don't we use that one anymore? Well, because that one damaged the enzyme DNA polymerase gamma the most. And each medicine does it differently. Some medicines really, really damage that enzyme because it really often mistakes it for reverse transcriptase. Others, they almost never damage it. Okay? Or when they do, it's really not a big problem. And this tells you which order does it the most. Now, DDC did it the worst. Really, really damaged that enzyme. Had lots of toxicity problems. Was very toxic. Had lots of side effects. So we actually don't use it anymore. Okay? Because we have newer, better medicines. But look what's next in line. DDI. Do we use that? Yeah, it's part of second line. Part of second line. So that causes the most side effects, doesn't it? Because it's the one that damages that enzyme the most. Look what's next in line. D4T. Used to be part of Regimen 1. 500,000 people in South Africa taking D4T, which damages that enzyme pretty highly. Look what's next in line, AZT. So what we used to do up until before April 1st, 2010, somebody was having a side effect of D4T, right? Developing lactic acidosis, developing peripheral neuropathy, developing lipodystrophy. We took them off of this one and put them on this one. Maybe helping a little bit, but look, they're right next to each other. And as I told you, they're very similar medicines. They're like brothers fighting over the same piece. If they're going for the same area, they're going to damage the same enzyme in the same spots. So we didn't have good options until 3 weeks ago. We didn't have good options in somebody who was having side effects of these medicines. Because our best option was AZT. But look, it's just the next toxic one. And it's very similar. But now we have new medicines that are now available, like tenofovir, like abacavir, and like 3-TC. Look where they are. They're all about equal. And they're much, 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 much less toxic than those other drugs because they don't damage that enzyme, mitochondrial DNA polymerase gamma, as much. It doesn't make that mistake. It doesn't mistake that enzyme for reverse transcriptase. It goes after reverse transcriptase only. And okay, sometimes it does get mitochondrial DNA polymerase gamma, but the body can deal with it. It can keep up with it. And so the side effects are much, 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 much less. And all of these newer medicines are about equal. And they have very low affinity for damaging that enzyme. Which is why the side effects in these 4 medicines are very, 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 very low. Patients on these medicines don't get much lactic acidosis. They don't get much lipodystrophy. They don't get much peripheral neuropathy. Why not? Because they're not damaging that enzyme. And that's why if somebody's having a side effect from one of these medicines that do damage the enzyme, we should be switching them to one of them that doesn't. So, mitochondrial dysfunction, damaging that enzyme, it can cause lots of the symptoms, lots of the toxicity that we talk about. Can cause peripheral neuropathy. Can cause muscle myopathy, which is muscle dysfunction. Cardiomyopathy, heart dysfunction. All of these from damaging energy. If these things can't make energy, if you can't make energy, the muscles don't work properly. If you can't make energy, the nerves don't work properly. If you don't make energy, the heart doesn't work properly. And as we talked about, because it's not working properly and lactic acid levels build up, they build up too high, that's lactic acidosis. What are the most common culprits of it? AZT, DDI, D4T. Why is it those 3? Why AZT, DDI, D4T? Because those are the ones on this side of the graph, right? Those are the ones that cause the most toxicity, because those are the ones that damage the enzyme the most. It can also cause pancreatitis, low blood counts. That's how AZT can do that, cause low blood counts. It can cause kidney dysfunction. That's how tenofovir does it. And lipodystrophy. Look at which they're the 2 that commonly cause lipodystrophy, D4T and AZT. What we were commonly doing is taking one and swapping for the other, right? Taking a medicine that causes lipodystrophy, changing it to one that can cause lipodystrophy, but maybe a little less. That's all the options that we have. So what is lactic acidosis? That's how it occurs, why it occurs, and which drugs do it. But what actually is it? Well, it's very vague. It's not like somebody having a heart attack. Somebody who's having a heart attack says, oh, they're having pain in the chest. It radiates down the left arm. They feel nauseous. Feels like pressure on their chest. They're having a heart attack. Somebody with peripheral neuropathy tells you, my feet are painful. They hurt. They burn. When I put the sheets on them at night, it's very painful for them. They feel numb and they're burning. Well, that's peripheral neuropathy. They're telling you. They're describing it for you. That doesn't happen with lactic acidosis. The symptoms are not specific. They're not exact. They're kind of vague. It might be weight loss, not feeling right, loss of appetite, okay? Just not feeling themselves. Okay? Sometimes belly pain. So it's nothing that's like specific, like the gentleman in the first case we talked about. If you weren't thinking about lactic acidosis, most of you wouldn't have said, oh, that's lactic acidosis. You say, I'm not sure what that is. He's just not feeling right. Maybe it's a virus. He went to the clinic. He got some antibiotics. They thought maybe he was having some infection. They thought maybe it was TB. But it's not anything that says, oh, hello, this is lactic acidosis. That's what makes it difficult to diagnose. The other thing that makes it difficult to diagnose is this other thing called hyperlactatemia, which simply means elevated lactate levels in the blood. That's hyperlactatemia. Okay. D4T is the most common culprit. It usually occurs after 6 months of treatment, but it can occur precipitously, meaning it can occur right away. Usually there's some degree of liver dysfunction in these patients. That's why I also say that you should check LFTs. Because the liver, along with the kidney, help to clear lactate. It's one of the jobs of the liver, one of the jobs of the kidney, is to get rid of extra lactate level when it becomes elevated. Patients are usually symptomatic when the level is over 5. They may or may not be asymptomatic with a level under 5. But because of how D4T works, because of how AZT works, because of how DDI works, patients who are taking these medicines, particularly for a long period of time, will have elevated lactate levels in the blood. They're going to have elevated lactate levels in the blood. The problem is it too much that the body can't handle, or is the body able to handle it okay? So when it's too much for the body to handle, that's what's called lactic acidosis. Lactic acidemia is simply an elevated level of lactate. So the normal level of lactate in the blood is less than 2.1. If somebody has a lactate level of 3, but is completely fine, is asymptomatic, they're not feeling any problems, asymptomatic, that's lactic acidemia. That's not dangerous. That's something that's very common in patients on ARVs because the NRTIs damage DNA polymerase gamma. They do. They will cause mitochondrial dysfunction. So you will, over a long period of time, many of you will develop elevated lactate levels. Many people will develop elevated lactate levels the longer they're on treatment with NRTI. But is the body able to compensate or not? And that's the difference between lactic acidemia and lactic acidosis. Now, lactic acidosis is an elevated lactate level with symptoms or with a low pH or decreased bicarbonate and an anion gap. That means the body is not able to handle it. It is not coping. It's not dealing with the elevated lactate, and it can't manage, and it's causing a problem. So that's when it's dangerous. That's when patients need to stop their treatment. Okay? So hyperlactatemia is simply an asymptomatic elevation of lactate, and it's common. 20% of patients every year on ARVs will develop it. So the longer they're on it, the higher the chance they will have of getting an elevated lactate level. This is the reason we don't recommend routinely testing everybody for lactate level. It's not part of your routine screening. You don't do hemoglobin, LFT, and lactate every 6 months. Why not? Well, because in many of them, it's going to be elevated. But it doesn't matter if they're asymptomatic, if their bicarbonate is normal. So this is one of the reasons we check UNE more frequently, because if the bicarbonate is low and the lactate is high, then that's a problem. Okay? So we don't routinely screen lactate. I know some clinics were. At baseline, they would draw your lactate level. Well, I was recommending against that because what's the point? Patients will have elevated lactates eventually if they're on ARVs. Now, there are actually lots of different ways of causing elevated lactate. Now, lactate is a byproduct of the pyruvate pathway, of an alternate way of making energy. And that happens lots of times. Not just from ARVs, not just from your NRTIs. Lots of normal things. Low perfusion. So if somebody's having low blood pressure or they're dehydrated, they can have elevated lactic acidosis. severe anemia can cause elevated lactate. Low oxygen levels from TB, from pneumonia, can cause elevated lactate levels. If they're having an infection like sepsis, they can have elevated lactate. Kidney failure, because the kidneys are one of the ways that the body gets rid of extra lactate. If the kidneys aren't working properly, then you can get elevated lactate. Diabetic ketoacidosis can cause elevated lactate. And also patients taking the diabetes medicine, metformin, or glucophage. Metformin or glucophage causes elevated lactate as well. So we usually recommend against patients taking metformin and D4T, because both of them together can cause lactic acidosis. But another thing that can cause, and one of the more common things that can cause an elevated lactate, is simply a lab error because of improper handling of the sample. Because what happens inside the body, right? Blood is supposed to be kept inside the body, right? Once you take it out, those cells start to die, right? When those cells start to die, they release lactate. And when those cells in there that are inside a tube, they start to use up the oxygen in that tube, don't they? The tube is sealed. Is there any more oxygen getting in there? No. So they're experiencing low oxygen levels. And the cells are dying. And so they start to release lactate if they're just sitting out in the tube. So ideally, if you want to run a proper lactate, it needs to be done immediately. It should be done from a free-flowing vein or artery. Why? If you put a tourniquet on the arm, what happens? You're stopping the blood flow. That's low perfusion. Over time, you're stopping the blood flow. The tissue's not getting oxygen. So you also get low oxygen levels. By squeezing it, you're also damaging the tissue. And tissue damage, I didn't put that on there, but tissue damage also causes elevated lactate. So by putting a tourniquet on and then drawing the blood, you're already causing an elevated lactate level. Not because the patient's developing lactic acidemia or lactic acidosis, just because of the way you're drawing the blood. The longer that blood sits out before it goes to the lab, the higher the chance of elevating the lactate. Almost every person in here works in a clinic where they don't run their own lab. So it usually takes several hours. A person may have their blood drawn at 8 o'clock. Your blood leaves the clinic at 12 o'clock. And then it gets sent to the lab. It may not get run till 4 o'clock. For a lactate, it has to be run within 2 hours. And it should be kept on ice for that entire 2 hours for it to be reliable. And that's the reason we use these rapid lactate machines, because it should be drawn immediately. And you should run the test immediately. Otherwise, the level is going to elevate. Not meaning that the level inside the patient's blood is high, but it's a false elevation because of the way the sample was stored or drawn. So what are the risk factors for developing acidosis? Well, females have a higher risk than men of developing lactic acidosis. It's a fact. And the reason is, you're not going to like this one, but the reason is the same as obesity. Because females have more fat than men. I'm not... No, it's just true. It's not that men are more fit than women. It's just men don't have breasts. Okay? Breast tissue is mostly fat tissue. So female have a higher proportion of fat than men, okay, because of breast tissue. And because they have more fat tissue, it's a higher risk of developing lactic acidosis. And this is the other reason we counsel our obese patients. One of the reasons we tell obese patients they should not take D4T is this. The risk of getting side effects is higher. The risk of lactic acidosis is higher because they have more fat tissue. Prolonged therapy. The longer you're on treatment, the higher this risk. Pregnancy is also a risk. And as I said, excellent adherence is a risk. If you're not taking the treatment, if you're not taking an NRTI, you're not going to develop lactic acidosis. You have to be taking the medicine for it to cause the damage, for you to get the side effects. And there are certain combinations like D4T and DDI together which gives you a very high risk of developing it. Now, why would these two give you the highest risk? If you take them together, why would they give you the highest risk of developing lactic acidosis? Yeah, they're the most toxic. It's number 1 and number 2 together, right? So you're taking number 1 and number 2 together. Of course, that's going to lead to the highest risk of toxicity. So what are the symptoms? As I said, they're vague. They're not specific. They're like nausea, vomiting, abdominal pain, weight loss, fatigue, shortness of breath, sometimes breathing fast but not short of breath. They can cause liver dysfunction, arrhythmia, meaning abnormal heart rhythms, and it can be fatal. People can die from it because they can get abnormal heart rhythms, they can get liver failure, low blood pressure, and shock, and they can die. But the one thing that you can check for, that I think, and it's one of the things that I use, because in order for lactic acidosis to be occurring, you must have mitochondrial dysfunction. If you're having mitochondrial dysfunction, it means the body's not able to make what? Energy. If the body's not making energy properly, it's not taking the food you eat, and it can't turn it into energy. It has to do it from another way. You're getting a side effect that almost every single person with lactic acidosis gets, and that's weight loss. Because you can't take the food and turn it into energy. Your body has to start breaking down fats. It has to start breaking down muscle. It has to start breaking down stored energy. Okay? Because it can't do it in the normal way. So almost every single time somebody's having lactic acidosis, they're losing weight. If a patient's gaining weight, they're probably not having lactic acidosis. It's possible because it can occur quickly. But patients who are having long-term side effects from lactic acidosis, almost always they're losing weight. So it's one thing that I use to check, to sort of be a screen for checking for lactic acidosis. Okay. So what is the treatment? Well, the main treatment is to stop the offending agent. The offending agent is the NRTIs, and as we learned in the resistance lecture, we don't stop one medicine, we stop everything. We stop everything. So we need to stop their ARVs. We need to stop the ARVs. There's not a great treatment for lactic acidosis other than that. Other than trying to wash it out of the body, sometimes with IV fluids, sometimes telling patients to drink lots of water, to help the body to wash it out, help the kidneys to flush out the extra lactic acidosis. There's been some investigational treatment with some B-complex vitamins like B1, B2, and L-carnitine. Haven't really been proven to work, but they don't hurt because they can help the body regenerate some of the enzymes that are damaged. So basically we give patients multivitamins, keep them well hydrated, and stop their ARVs, and that's the main treatment of lactic acidosis. So because of this difference between lactic acidosis, lactic acidemia, symptoms, no symptoms, there's sort of been a suggested algorithm, and I sort of keep this in the back of my mind whenever I'm evaluating somebody with an elevated lactate. Now, if you draw somebody's lactate, it should be because they have symptoms, right? Otherwise, you shouldn't be drawing. So if it's less than 2, that's normal. Their problem's not from lactic acidosis. If it's somewhere between 2 and 5, which is most of the time when we draw it, what it is. Okay? You can do this watchful waiting if they're asymptomatic, or if you think their symptoms are probably from something else. But if you're thinking that their symptoms are from lactic acidosis, then you need to stop the ART. So how do you know? Is this symptoms because of lactic acidosis or not? This is where I tend to use weight loss. Are they losing weight? If they're not losing weight, their symptoms may have just started a week ago, then I think you might be safe in watching them, have them come back to the clinic in a week or 2 weeks and repeat the test. Check their weight again. But if they're losing weight, it's been going on for a long time, their weight's not picking up, there wasn't picking up for a while, and now they're losing weight, their lactate is now 3.5, they're coming in with nausea, belly pain, going on for a month, well, they need to stop their ARVs. If they're having symptoms and something is worrisome, they're losing weight, they're not feeling right, and their lactate's high, it's over 5, well, that's serious. Okay, that's very high lactate level, and you definitely need to stop their treatment at that time. Okay, you would also check a UNE and check for acidosis or low bicarbonate, check their anion gap, and you would possibly hospitalize them, add vitamins, and make sure you stop their ARVs. So most people, even if they're asymptomatic, if they have a high lactate over 5 and asymptomatic, they still stop ARVs. Okay. If the lactate is extremely high, even over 10, even if they're asymptomatic, you should definitely stop their ARVs, okay, even if there are no symptoms at all. So when do you restart? When do you restart treatment? One, you should be consulting with an expert first, before you restart treatment. But you want the lactate to start to become normal, usually less than 3 or even better, less than 2.5. Once the lactate becomes less than 2.5 and their symptoms resolve, they're no longer acidotic, meaning their pH is now normal, their bicarbonate is now normal, then you can consider restarting. And what do you restart? Well, you would not want to restart their D4T because that's probably the cause of it in the first place. In mild cases, actually I'd delete this from my slide, but with the old guidelines, when we didn't have tenofovir or abacavir, I used to say change to AZT because that's all we had. Now I would say even in mild cases, do not change to AZT, change to tenofovir or abacavir. So even in mild cases, we should avoid something that can also cause the same problem. As you know, AZT can also cause the same problem. In severe cases, patients should avoid taking 2 NRTIs. Okay, and they could take Kaletra, Stokerin, and 3-TC. Now, this is not an ideal regimen. This is sort of a dangerous regimen because if they fail that regimen, there's nothing left for them. They're using a protease inhibitor and an NRTI together. So it's not the most durable, it's not the most potent regimen there is. So that's for extreme cases. Okay. Any questions about lactic acidosis? How often do you repeat the test? Excellent question. It depends. Some patients resolve. The question is, how often do you check the lactate level? Usually what I do is initially I repeat it in 2 weeks. So stop their ARVs and repeat it in 2 weeks' time. Some people by then are coming back into normal with the lactate less than 2.5. So initially I usually check it about every 2 weeks. So I'll see them in 2 weeks. If it's still high, I'll see them in 2 weeks again. So now this is 1 month after you stop the treatment. If it's still high, then I'll usually see them every month until it comes down. Some patients it takes a while. Some it takes 3-4 months before their lactate level becomes normal and you can restart their ARVs. Okay, so it sometimes does take a while. Any other questions about lactic acidosis?
Lactate, because we're taking the lactate using the arbitrary machine, and then it's 1.8, and then we send blood to the lab, and then it comes back, it's 3.5, and there was always that.
Why?
Why is it like that? And then when we want to do the change of regimen, it becomes an issue. Then maybe the pharmacist will say, I trust more the formal one than the artificial.
Yeah, usually I would not. So this is an excellent point. She says now she understands why when you use the AccuTrend, machine and it says 1.8. But yet you send the formal one, which was supposed to be the better one, to the lab, it says 3.5. And you say, oh, stop the treatment, it's 3.5, patient symptomatic, this is lactic acidosis. But in my mind, which one is more accurate? Because which one is more accurate? The one that sat out all day, sat in the sun, was spun down, never on ice, and done 12 hours later? Or the one that you did immediately? The one that you did immediately is probably more accurate. And again, different things will do it. Now, you know, coming from a person who draws blood and draws blood on children, sometimes it's very hard to draw blood without a tourniquet. So you sometimes have to do a tourniquet. Okay? So there's different things that are going to give you different and more reliable lactate. The best thing is a free-flowing vein or artery. Never using a tourniquet, just taking the needle right in and immediately doing the lab. But if you can't do that, because sometimes you can't, I think the next best thing is a finger prick, a capillary. So you could do a finger prick, and then to check a quick lactate, you can do it that way. That's going to be slightly more elevated. Why? Because usually you have to squeeze. And again, by squeezing it, you're causing tissue damage, and then that's going to falsely elevate it. But usually it's not that much squeezing, not for that long period of time. So although that's a little bit higher, it's a little bit more reliable. If you can't do that, you have to use a tourniquet to draw blood. That's the next highest thing. Okay? So keep in mind, if you get it, you've drawn a tourniquet, and it's 2.3, that might still be normal. That might still be normal. Even 2.5 or 2.6 from a tourniquet might still be normal. So there's different things that will sort of elevate that lab, and you have to say which one do you trust the most. Right, and you have to make sure the machine is calibrated and working properly, of course. And that's the problem with the AccuTrend machine is making sure that they're calibrated and working properly. Sometimes they get contaminants in them, sometimes blood is spattered all over them, and they get dirty and then they don't work properly. So you need to make sure that your machines are working properly. Okay, lipodystrophy, another and next most common side effect. Remember our case and the patient I also saw on Tuesday, female, 35-year-old on 1A, CD4 response fantastic, viral load response wonderful, undetectable, but she's saying, I'm getting fat. My clothes don't fit anymore. I'm spending too much money buying more. It was routine blood, and they knew that they were going to change her to AZT, so they just thought as a baseline they would check the hemoglobin. So there was lots of problems with the way that case was managed, and it left her... Yeah, and it was left her really, because of the poor management, and because of just immediately switching somebody for lipodystrophy, it really limited her second-line options, and she really didn't have any good second-line options. So she could have already been resistant to second line. Okay. So what could we do to avoid that? So some of the people, I've heard some doctors say this right here. Well, lipodystrophy is not life-threatening, so who cares? Why should we change treatment? Say, you know what? You're gaining weight. So what? It's your problem. You're not going to die. Well, was it life-threatening in this woman's case? It was, because she wasn't taking her treatment. So although it's not life-threatening, it can also impact self-esteem. Some people say you can disclose your status because of some forms of lipodystrophy, like fat atrophy. And it impacts adherence. If you don't like the way that you look, you're not feeling right, your breasts are becoming too large, your clothes are not fitting, you're not going to take your treatment. And if you're not taking your treatment properly, is that going to affect adherence? Yes. And that affects resistance, and then that can affect your life. So it can be life-threatening. Okay? And it can also accelerate the hardening of arteries and diabetes. So treatment and addressing it can actually improve patients' quality of life. So it is not something that you should ignore. Now there's really three forms of lipodystrophy. There's lipoatrophy, which is fat atrophy, so losing fat. There's fat accumulation, and there's mixed. So getting a bit of both. So what is fat atrophy? Now, this is one of the more common forms of true lipodystrophy. It's a loss of subcutaneous fat in the face, in the buccal folds, which is like the cheeks right here, in the arms and legs. So you start to lose fat in the arms and legs. Women say they start to look like bodybuilders because the veins are more prominent. And in the abdomen, which is hard to tell, I'll show you why, and in the buttocks, okay? So these are some pictures of some men with lipodystrophy, and you can see what I'm talking about, losing fat in the face, and you can see it starts to indent here in the cheeks, and it can even be more severe like in these cases here, okay? So pretty severe lipodystrophy, fat atrophy. The other place that you can see fat atrophy, not just the cheeks, is the temples. You can see this woman losing lots of fat here. I mean, this looks like a person with advanced HIV and advanced AIDS, but she was on treatment for a long period of time, had a high CD4 undetectable viral load. Okay? You can see she's losing fat from that area. Okay? Now, most people, when they think of lipodystrophy, they're always talking about the belly, right? The belly is not the place to find lipodystrophy because of this. You can be obese with a lot of subcutaneous fat, okay, and a little bit of visceral fat on the inside. Or you can have visceral obesity with lots of fat on the inside, but the skin subcutaneous fat is very little. Now, the circles are both the same size, and you can't tell which is one and which is the other. So you could be losing fat from the inside or from the outside, and you can't tell because there's fat inside and there's subcutaneous fat outside. The only way to tell the difference is to do a CT scan or MRI, which obviously you can't do in all your patients. So it's not the best way to do it, okay? So what are the risk factors of developing lipodystrophy? Well, high viral load at initiation is a risk factor for developing it. The problem with that is every single patient in South Africa has a high viral load at initiation because we initiate very, very, very late. So most patients do have extremely high viral loads at the time of initiation. Older age is also thought to be, and also lower CD4 at initiation. So already everybody in South Africa is at risk, right? Because we start at low CD4s and high viral loads. So most patients are at risk. Okay. So what is the cause of the fat atrophy? Why are they losing fat? Well, it's from mitochondrial toxicity. The same thing that causes lipodystrophy, the same thing that causes lactic acidosis. The body's not making energy properly.